We're going to talk about infection. So for infection to happen, there first has to be colonization. That is the organism, whether it's a virus or a bacterium or whatever it is, has to exist in a reservoir somewhere in the environment, whether it's in rats or in mosquitoes or in birds or what have you, or there has to be human-to-human transmission. So this colonization is the first thing that happens. Then invasion, where the bacterium or the virus or whatever penetrates the host and begins to evade the host's defenses. Then the infectious agent multiplies and then spreads. That's the process of infection. Probably not much to know there. You, I'm sure, already know that. As you do the infectious disease stages. So remember, the incubation period is from exposure until symptom onset. Once initial symptoms happen, that's the beginning of the prodromal stage. And then the invasion period is where there's the immune and inflammatory responses that are triggered. And then the convalescent period is where symptoms begin to decline, though certainly there could be reactivation at some point. The pathogen to disease, there's all these terms that you should know. Communicability, the ability to transfer the infection from one place to another. Immunogenicity, the ability to stimulate the immune response. Infectivity, you know these terms, so we won't spend any time going over them. You also know that from a couple of lessons before that the brain is fundamental in fever. But the reason that fevers happen is really because of those cytokines that are produced, and they have a systemic effect on a particular area of the brain, the hypothalamus, that contains the temperature regulation center. And when that temperature regulation center senses these interleukins and tumor necrosis factor, etc., it begins the process of heat generation, and the result is fever. Inflammation, hugely important in this, right? We have an inflammatory response when there's an infection present. Make sure you know this information. So now is probably not the time that I need to teach you the difference between endemics, epidemics, and pandemics, right? I think we're all pretty clear nowadays about what a pandemic is. So I'll let you review those on your own. Know that the classes of infectious microorganisms are these. The most worrisome, the most fear-inducing of all of them is, what do you think? The one I'm scaredest of are prions. Prions are super frightening because they really only are proteins. They're just the protein coat. The virus is just the nuclear component, DNA or RNA. Prions don't have DNA or RNA. They are just a protein. Very, very terrifying. How can something that's not even alive kill you? And it kills you. This particular one can kill you by giving you Creutzfeldt-Jakob disease, which we get from cows that are infected with bovine spongiform encephalopathy, though you most probably know it as mad cow disease. So prions, terrifying. I am very nervous about them. We're learning to deal with viruses. We've gotten pretty good at dealing with bacteria, but they've gotten pretty good at dealing with us too. And we'll talk about that. If you didn't watch that video from Harvard Medical School that shows the giant petri dish on a table, watch that. It's terrifying. You know that that those bacteria are figuring out our positions on things, and these infectious agents are very scary. Fungi, of course, typically molds and yeast are relegated to being a problem in patients who have immunodeficiency. But we are, we certainly have the possibility that they will become more worrisome in the future. And in fact, we're already at that point where there is a fungus that is out there that evades all of our known medications and is a particularly scary critter. Now, what the future holds for that, we're not sure, but it is something that is on the radar of infectious disease specialists around the world. Then protozoa and parasites, of course, we'll talk about them briefly as well. Let's start with bacterial infections. Among the things that we see most often clinically, the true bacteria are the ones that are spherically shaped, or the cocci, and rod-shaped, or the bacilli. But there's also other shapes too, and we have some of these that are filamentous, that have filaments that make them look like fungi. We have spirochetes. Of course, the most famous spirochete of all is what? Treponema pallidum, which is syphilis, right? So spirochetes, very concerning. Syphilis, but also Lyme disease as well. Mycoplasma are the smallest bacteria. The one that we know most often is Mycoplasma bacterium, or TB. We have to classify things in order to have order, and for us to develop treatments and things, we need to classify microorganisms. So we talk about classifying them by their shape. That was what we just talked about. But we also classify them according to characteristics of staining. For instance, gram staining, the gram stains, and we get gram positive and we get gram negative results. Gram positive tend to be a little less complex and typically a little easier to kill, right? So a little easier to deal with. The gram negative have a whole lot more things going on here, right? All the stuff that's going on, we can see it's much more complex, and as a result, they are a little more challenging to kill. So we get a little more nervous when we see gram negative, because we have to do more things to be able to, or have special tricks up our sleeves in order to get those organisms under control. The other way that we classify things is by aerobic and anaerobic, whether they reproduce in the presence of oxygen, require oxygen, or whether they don't use oxygen. Now, what I've noticed over the years is that the bacteria that are anaerobes may often be our own normal flora, but they get into an area, they form an abscess. So they form an abscess in an area like, around the tooth root or in lung tissue. That abscess doesn't have blood flow to it. It's just a collection there. And that collection is kind of the important term. When you hear us talk clinically about somebody having a collection on X-ray or on CT scan, the collections are bad. They're never stamp collections or coin collections or something cool. They are bad news. And the bad news comes because bacteria grow in there, because it's a warm, dark, moist environment. And what do bacteria like? Warm, dark, moist environments. And that warm, dark, moist environment is not getting any blood flow, so there's no oxygen there, and that's why we end up with these anaerobic infections in places like skin, which is cellulitis, or any number of other areas. Okay? So I just wanted to remind you of how complex this stuff is, but also give you a cheat sheet for being able to organize these things in your head. And you can see that the area to click on is down here at the bottom. You can click on that and go directly to this Mass General Hospital infectious disease guide. One of the things that you'll see is when the gram stain on the first day of cultures that we don't identify the organism necessarily because we don't have enough information yet, but we can look under the microscope and see that that there are organisms that meet certain criteria. They are perhaps gram positive. They have a shape to them that are cocci, and they may be in clusters or in pairs or in long chains. Okay, and those clues can help us to know what the organism is before it's identified. If it's cocci in clusters, the thing that usually ends up being is staph. All right, usually gram-positive cocci in clusters are Staph aureus, but that's dependent on whether the coag test is positive or negative. If they're coag positive, then we know that they are staph, right? And then they won't say that they are coag positive, gram positive cocci in clusters. They'll say it's Staph aureus because that's what identifies it. Okay? But keep this on you when you're doing clinical, and this will help you to be able to identify what these organisms are from the start. So gram-positive rods, you can see can indicate Clostridium, Listeria, and other bacteria. Okay, there are several of these methods of looking at this. One way to do it is with this descending tree. So we start with gram-positive, and we see that there are cocci. Now we see that they are catalase positive or catalase negative. And then if they're catalase positive, then they are Staph aureus, or they are Staph epi, or this one, which I don't recognize. Okay? So again, use this to help you when you're in clinical, figuring out what some of these organisms are. This will be a very good cheat sheet. Here are the gram negatives. Here are the acid-fast bacilli. Whenever you see an acid-fast bacillus, that's mycobacteria. That's TB or some other mycobacterium, but never a good thing. The spirochetes, as we said, treponema, that is syphilis. Borrelia is Lyme disease. Okay? And then the fungi are also shown here, so you can see that yeasts are unicellular, molds are multicellular, and there are cheats there for you to recognize which is which. Well, that's all well and good, but what does it mean? Well, what it means is that there are certain drugs that we know empirically should be good to treat those infections. And there are any number of these cheat sheets out there. I just pulled one off of Google and put the references down here at the bottom, so you can check those references. But let's look here, and we see that we have E. coli, for instance. E. coli is a gram-negative bacillus, and we know that the first generation cephalosporins are very good for them, and they have this coverage range right here. So they will cover this entire range with cefazolin or cephalexin. So just as an example, this is the antibiogram that will help you to pick empirically useful drugs for treating infections. Now, I want to spend a little bit more time here because it's so important. This is our little animated, it's supposed to be animated. I'm not sure why he's not jumping around on the screen, but this is an animated asterisk that I want to use this semester to really cue you into the super important stuff. And this is one of those things that's super important. Remember all of these cytokines here, right? Cytokines. Cytokines should be at low quantities in local tissue. And when they are, they pull in monocytes, macrophages, neutrophils, and activate them. They activate endothelial cells. They activate complement, and that results in local inflammatory condition. When there are moderate quantities of these cytokines, in moderate quantities, we get a little bit bigger response. We get fever, for instance. We get acute phase reactants from liver processing. We get more leukocytes coming from the bone marrow, and these systemic effects are useful, right? We like these things. What we don't like is when we have cytokine storm, where there's just this excessive amount of cytokine that shows up and goes systemically throughout the system and results in myocarditis. Okay, myocarditis, bad. Can result in blood vessel injury, can result in DIC, disseminated intravascular coagulation, can result in this horrible inflammatory disease called ARDS, and all of those things are functions of septic shock. So the cytokine overactivity, when this stuff gets going in major ways systemically throughout the body in an uncontrolled way, such as happens in COVID-19 pneumonia, we can have the cytokine storm that results in all sorts of badness. Myocarditis, DIC, injury to the vessels, ARDS, septic shock. Okay? Other things for you to know about are endotoxins and exotoxins. So exotoxins are usually from gram-positive organisms, and these are proteins that are released during bacterial growth, and these antitoxins can be given through vaccine. All right, so DTaP for one is an example. Endotoxins are a little different. Endotoxins, typically gram-negative bacteria that cause endotoxin release. These are pyrogenic bacteria. They cause septic shock, among other things. And so when you have gram-negative sepsis, it's the endotoxin that is largely responsible for those outcomes that we're concerned with. Now, remember we talked, I sort of alluded to it earlier, that the bacteria are getting pretty good at dealing with our mischief as well. So we're getting better at treating infections, but they're getting better at resisting infections. Well, the bacterial defenses against immunity and our inflammatory response are these things: rapid division, intracellular survival, that is, they can survive inside phagocytes. How weird is that? Right? So that's not all bacteria, but that is one bacterial defense against immunity and inflammation that bacteria have developed, the ability to survive inside of phagocytes. They can coat themselves with antigens that are recognized as self by the body. They have antigenic variation. That means that they can switch and change inside the host. They can degrade some of our immune molecules, some of the complement and things like that. They can neutralize some of the immune molecules, and they can suppress the immune response. So these are some examples of how those things work. Very scary. There are specific tissue damages that can happen from bacterial infection. And so we know about some of these toxins that happen, like with Clostridium, botulinum, Clostridium difficile. These toxins can produce well-known effects that we're familiar with. Indirect damage can happen through inflammation, right? So the fact that we have a bacterial infection means that we're going to have an inflammatory response, and that inflammatory response itself can be detrimental to the host. There can be super antigens where the toxins produce a pro-inflammatory response, like in toxic shock syndrome. And then we can have endotoxic shock that activates the coagulation cascade. And all of those things are bad, and some of the potential effects are shown here. More of the particular bacteria that cause damage in different areas of the body. So H. flu, for instance, affects the upper respiratory tract. The lower respiratory tract can be affected by E. coli, right? This is the lower respiratory tract infections. E. coli, H. flu, Klebsiella, Legionella, etc. So I gave you these so that you have some reference point, not to memorize, but so that you have these in your pocket when it comes time to deal with real clinical patients. Fungal infections, you know that we have molds, which are multicellular organisms, and yeasts that are single cell organisms, though they may live together in an environment. They are eukaryotic microorganisms, that is, they have DNA or RNA, and they can form all sorts of complex structures. So fungal infections are transmitted typically by inhalation or contamination of wounds, because just like bacteria, yeast like warm, dark, moist places as well. So we have yeasts such as Candida, Aspergillus, Cryptococcus, and we also have all the dermatophytes, the tinnias, that we get from human to human transmission. Colonization happens by adherence to the epithelium by these sugars that are on the fungal surface. They actually stick to the epithelial surface, and that's how the colonization happens. Invasion then requires some intracellular survival and adaptation to the host environment. And then we have fungi having a mechanism where they can protect against phagocytosis. They produce some toxic metabolites that inhibit phagocytosis. So that makes it harder for us to defeat them, particularly in immunosuppressed, right? So immunosuppression is really a major problem where we see fungal infections. Here's some examples. This, of course, is Candida, and it's an opportunistic infection where there's normal flora, but this Candida overtakes that normal flora and grows out of control. There are parasitic and protozoal infections. Parasitic organisms like to establish symbiosis. So they only do well when we do well, right? So these worm infections happen often in the gut, and they use the food that is ingested by the human organism, and so we share that food supply. As a result, these worms reproduce wildly and are using the energy that we're trying to get for our bodies. So although both worm and host can exist together in this symbiotic relationship, neither one really flourishes, right? And then protozoa are themselves eukaryotic unicellular organisms, and malaria from Plasmodium is shown here. So you can have these little Plasmodia critters inside the red blood cells here. So these are rarely transmitted from human to human. They are almost always through a vector, and mosquitoes are common for malaria. The colonization happens because the vector injects the parasite into the person, or the person eats it or drinks it through the GI tract. So this is the malaria life cycle that's shown on this CDC borrowed image. Malaria is the most common infection worldwide, and it's transmitted through the Anopheles mosquito. The parasite enters the blood, survives in the liver, and then invades the parenchymal cells in the liver, right? The liver's parenchymal cells. After several rounds of division, then that cell ruptures, and all these parasites start floating around in the blood. Then they infect the red blood cells, and the red blood cells then become part of this cycle as well. There's a sexual cycle and an asexual cycle, and the drugs that we use are aimed at that particular cycle, whether it's the sexual reproduction or the asexual part. Next, we should just talk about the viral infections, since we're in the middle of a viral pandemic right now. You know that viruses are very simple microorganisms. They are a protein coat and nuclear material, either RNA or DNA. And they exist on their own. They cannot reproduce by themselves. They have to get into our cells, overtake the DNA or the RNA in our bodies, and reproduce that way. So that's how viruses work. Of course, we all knew that. And the process is shown here. The virion enters the cell by getting onto the receptor here, and then it penetrates, and then it gets uncoated here, and then it goes into the nucleus where it takes over the machinery, replicates, assembles and matures, and then those new viruses are released out into the wild. And by the wild, I mean into the bloodstream. So, influenza is a very common virus. I thought it would be useful for you to know the origin of influenza. There are something like, I don't know, there's an innumerable number of virus classifications. We'll talk about this H and N classification system for influenza. But notice that they come from all sorts of vectors. We get cats and tigers, chickens, which is where a lot of ours originates, the avian world. We have human influenza viruses. Whales have influenza viruses. Wonder how that works. Because, like whales don't get together and cough, right? So, I don't know. There are swine versions here, and the ferrets get into it. We have horses that can get it. And all of these have the potential of jumping from the equine organism, for instance, into humans. And that could be completely disastrous. Now, usually that doesn't happen, and I guess there are lots of reasons that it may or may not happen, but that's sort of beyond our scope here. So we have two ways of classifying influenza viruses. The naming convention is shown down below here. This is the naming convention. And notice that we start with type A or type B. Next is the area of origin, whether it's Hong Kong or Spain or what have you, Middle East. These viruses are classified according to where they were first encountered. And then we have the strain ID number, and I guess that's done with DNA or RNA typing, and then the year that it was isolated. And then these two numbers, the H and N numbers, these are really important. The hemagglutinin is the H number, and there are 18 different H subtypes. And there are about 11 different N subtypes. And with those, we can have any number of these combinations. We can have H1N1, which is a pretty common one. In fact, you can see it right here. We could have H3N2. And guess what? That happens to be a very big component of what we're encountering this year in 2021 to 22. So the predominant strain that we're seeing is H3N2 this year. But there's other ones too. There's H3N2V, etc. So these are this is the method that we use to classify influenza infections in the U.S. While we're talking about viral illnesses, maybe we should talk about COVID-19 pathophysiology a little bit. What we've learned over the years, and this actually comes from an article in Nature in July 2020, so it's not the most up-to-date, but this is what we knew at the time. Now, at the time, we were 6 months into the pandemic or so, right? But guess what? We've had experience with coronaviruses for a long time. For 9 years before this, we've had experience with coronaviruses. Not the novel coronavirus, but plenty of experience with SARS from, what was that, 2003, I think. So what we know is that there's this viral entry mechanism that consists of these spike proteins, right? These spike proteins adhere to the ACE2 receptor that's typically located in the lungs, okay? And when that binding takes place, that starts this whole cascade of events right here. One of them is a direct cytotoxic effect. So this viron hits the ACE2 receptor and causes a direct cytotoxic effect. Then there's also dysregulation of the renin-angiotensin-aldosterone system. Does that make sense? Well, yeah, it makes sense because it's part of the angiotensin 2 receptor, the angiotensin converting enzyme 2 receptor, that is part of this renin-angiotensin-aldosterone system. And so there is tissue remodeling, inflammation, vasoconstriction, and vascular permeability, which is critically important because we know that they develop this ARDS-like lung condition where there is this fluid that leaks out of the interstitium and causes problems with oxygenation. There's this endothelial cell damage and thromboinflammation. We know that thrombus formation is another issue that happens, and we equate it to increased thrombin production. Studies have been done that show people have better outcomes if they present with mild to moderate disease and we start anticoagulants right away. They do better than if we don't. And then there's also this dysregulated immune response, which happens because of this cytokine storm, right? We've been talking about these darn cytokines, and this is a big part of why COVID-19 is such a terrible illness in certain patients, because they have this cytokine storm that we can't recover from. There are many, we talked about on that last slide, most of the pulmonary effects, but there are extra pulmonary effects too. And many of these things are what we've seen affected by long COVID symptoms. So the headache, the encephalopathy, the Guillain-Barré syndrome, the fogginess of thought. We can also see acute kidney injury, both with proteinuria and hematuria. We can see transaminase elevations. I see that regularly in our COVID patients. Diarrhea, nausea, vomiting, abdominal pain, etc. And Endocrine can cause hyperglycemia, and we can also see diabetic ketoacidosis. I've seen that as well. Thromboembolism, as we talked about. We may see Takotsubo cardiomyopathy, which is essentially stress-induced cardiomyopathy. But the other thing that we are really concerned with in this group is myocarditis. That's another major issue. We don't see it very often, but it's certainly a potential issue. Now, what has been unexpected is the development of this long haul phenomenon. This post-COVID syndrome has several different mechanisms that we're concerned about. It may be, and we don't really understand it well yet, but it may be that there's direct viral toxicity that's responsible for it. There may be endothelial damage and microvascular injury that are still persistent after a period of time. It may be the immune system dysregulation and that hyperinflammatory state that's to blame. We don't know. It could be hypercoagulability with some in situ thrombosis. We don't know. And it could be maladaptation of that angiotensin converting enzyme 2 or the ACE2 pathway. We don't know. It could be any of these things. It could be all of them. It could be none of them. We just don't know at this point. Studies are ongoing so that we can learn more.